Welcome. We'd like to thank you for joining us at OrthoNeuro's Hip Pain, You Have Options educational webinar. Tonight's speaker will be Dr. Ryan Palmer. Dr. Palmer is a board-certified fellowship-trained orthopedic surgeon who specializes in hip and knee total joint reconstruction. During Dr. Palmer's presentation, please feel free to click on the Q&A box at the bottom of your screen and type in questions, which Dr. Palmer will answer questions following his presentation. Dr. Palmer?
Thank you, Heather. I'll go ahead and share my screen, and we'll get started. Thanks to all the participants today. Hopefully we can learn something about hip pain. What we're going to do here today is talk about some common locations for hip pain, as not all hip pain is created equal. We'll talk certainly about some conservative management options for different conditions that can occur around the hip, and eventually talk a little bit more directed about hip arthritis and surgical options in anterior approach total hip arthroplasty. As Heather mentioned, please feel free to type in some questions, and we'll have some time at the end to be able to go over those. So the first question I might ask you if I saw you in the office is, where exactly is your hip pain? There can be pain that can occur in the front of the hip, on the side of the hip, or in the buttock region. And that's all very important to understand in terms of what your underlying condition may be. This graph right here does a good job of showing what different forms and different locations of hip pain can be caused from different conditions. Certainly posterior pain is typically more back-related pain. It can be focused around the sacroiliac joint, or what we know as the SI joint. There are some different bursa sacs posteriorly that can be inflamed. That could be just inflammation of the bursa, or what we call bursitis. Side pain is often that as well, a bursitis type of pain. It's typically the anterior hip or the groin pain that is the hip joint itself. Sometimes the hip joint can refer pain into the thigh, sometimes even in just to the anterior aspect of the knee. So different locations of pain can key us into what your underlying condition may be. I would say the top three causes of hip pain that I see in my office are associated with the lateral hip pain that we mentioned a second ago, associated with bursitis, what we call greater trochanteric bursitis. And this is also often associated with a soft tissue condition called iliotibial band syndrome. And we'll talk about this. Certainly anterior pain, pain within the groin and the front of the thigh, and even into the upper portion of the front of the knee, can be arthritis from the hip joint itself. And then posterior pain can certainly be from the back, the lumbar spine, that can be what we call referred back pain. Greater trochanteric bursitis is pain that is palpable and tender directly to the touch over the lateral part of the hip. This is actually the upper part of the femur bone on the side of the hip joint. This is irritation of the bursa. The bursa is there as a normal anatomic structure to pad the bony prominence of the upper part of the femur, but it can be irritated. And that's why it has the itis on the end of it, what we call bursitis. It can present with difficulty lying directly on the side, particularly at night. And often then, when we elicit this diagnosis, we want to know, why are you limping? Is there some reason in your lower extremity that is causing you other difficulties, causing you to limp? And we see different causes of a limp, whether it's in the foot or in the ankle, knees, and the hips themselves. But this can cause overuse of the gluteal musculature that attaches into the area where the bursa lies, thereby creating a bursitis and often a concomitant tendonitis at the same time. If we can treat the underlying cause, we can often treat the cause for the bursitis being there in the first place. Also associated with bursitis is a very universal diagnosis that I see in my hip and knee practice, known as iliotibial band syndrome. The iliotibial band is a soft tissue structure that attaches from the ilium, which is the portion of your pelvis, actually the iliac crest, which is a portion of the pelvis. And it travels down the side of the leg and attaches to the top of the tibia or your shin bone. Essentially, we have a number of muscles that come together and essentially form this tendinous band of tissue that can become tight over time. It can become tight from not stretching or not being as active as you would like to be. It can become tight due to lack of range of motion, due to other underlying conditions. Whatever the cause, it is often a progressive condition that will start to provide irritation at the red marks located on the diagram. Again, located directly over the side where the bursa also is located, and over the side of the knee. Irritation over the side of the hip, again, is associated with bursitis, and irritation over the side of the knee is a condition called runner's knee, both that can be caused from limping and overuse or compensation. When we determine bursitis as a cause of lateral hip pain, we treat the inflammation with anti-inflammatory medications. This can be a combination of oral anti-inflammatory pills. If there is any contraindication to oral anti-inflammatory medication, either intolerance to the medicine, or maybe you're on a blood thinner and you're not allowed to take those medicines, maybe you've had gastric bypass surgery and are not allowed to take those medicines, whatever the reason, then we'll typically go to a topical is lying on a foam roller. One of the better ways to stretch the iliotibial band is lying directly on that IT band with a foam roller and stretching accordingly. Likewise, this can be done by a massage therapist or a manual physical therapist. There's a number of ways to do that, but foam rolling is one easy way to do this at home. There's also physical therapy and associated home exercises. You can see the other woman in the other diagram that's working on a lateral stretch of her IT band. There's many forms of this as well, but it's understanding the anatomy, it's understanding how that's affecting your bursitis, and doing daily stretches to improve that. We also do steroid injections into that area for further delivery of anti-inflammatory medication. And then if persistent pain is still present, even after consistent treatment, sometimes an MRI or advanced imaging will be warranted to rule out other issues, such as a tear of the gluteus medius tendon that can be a cause of unresponsive and continued bursitis pain. This diagram here shows in a diagram form where the bursa is located over the lateral hip. And in the office, this can quite easily be done under direct palpation of where the soreness occurs and injected with a steroid medication. This is often combined with a long-acting local numbing medication to provide fairly immediate relief and really start the process of pain relief. These can be typically re-injected every 3 to 4 months, as long as we're seeing improvement and we don't need to go to further advanced imaging to rule out further diagnoses. Then we go to the hip joint itself. As I mentioned before, the location of pain for the hip joint itself is typically in the groin, in the front of the hip or in the front of the thigh. Every once in a while, the hip joint can register as a deep posterior buttock pain, but typically posterior pain is referred back pain or the SI joint. So we're going to focus on the anterior hip pain, where hip joint arthritis typically manifests its pain. Arthritis. It's a very common term. Everyone's heard of arthritis, but it's often not defined very well. So what is osteoarthritis? Osteoarthritis is simply the wearing down of the articular cartilage within a joint. And it doesn't matter if we're talking about the hip joint today or the knee joint or any of the joints in your fingers, anywhere in the body, our joints are covered by a capsule. And the capsule keeps the joint fluid in. The joint fluid nourishes the cartilage layer. On the diagram here in front of us, the cartilage is represented as the purple substance. Folks may understand this as the white shiny on the end of a bone, either at end of a turkey leg or a chicken bone. That cartilage, when it wears down, is how we determine the presence of and define the presence of arthritis. Arthritis literally means inflammation of the joint. That is what causes us pain, but the underlying driver for the creation of the inflammation is the wearing down of the cartilage. And this can come primarily from someone's genetic predisposition. It certainly can result from previous injuries, previous surgeries, or repetitive work environments and work activity. It can even be associated with increased weight, just from the fact that there's increased stress on the cartilage. But the primary driver for osteoarthritis is genetics. Hip osteoarthritis, as mentioned before, typically causes groin pain, an association with anterior thigh pain, and even every once in a while it will skip the groin and skip the front of the thigh and present as anterior knee pain. It always presents with a decrease in range of motion of the hip joint with internal and external rotation. And that provides for clinical challenges with simple daily tasks such as putting on your shoes and your socks, trimming your toenails, and even getting in and out of a vehicle. Those three daily activities are universally difficult with advancing hip osteoarthritis. So what are your options? When we simply break it down, we have non-operative management and we also have surgical management. From a non-operative standpoint, conservative treatment includes as many treatment modalities as possible for the greatest relief. There's probably not one main treatment that's going to elicit all of our effect, but again, as many treatment modalities as possible for greatest relief will be a good treatment protocol. And then there's surgery. So we're going to break these down today. Conservative treatments consist of, quite simply, lifestyle changes and activity modification, beginning to limit those activities that cause the most discomfort, certainly resting adequately from physical activity, or again, those activities that cause most discomfort. ICE is a very simple anti-inflammatory measure to decrease the inflammation that arthritis can produce. We want to make sure that we're managing our weight through good diet and exercise. Sometimes that also includes physical therapy or a weight loss program, depending on how elevated the weight has become over time. We'll sometimes need walking aids such as canes and walkers to offload the joint. This can be temporary, this can be permanent. But certainly certain medications and injections are often part of the treatment as well. Medication management is a very common way to help with the inflammatory pain that arthritis produces. We typically start with a over-the-counter non-steroidal anti-inflammatory medication. These will be things that we are all familiar with over the counter, such as Aleve or Advil and Motrin. Both of those medications, and I'm certainly not here to promote any specific medication, but naproxen or ibuprofen that are in the over-the-counter medications are great medications, but they only last so long. Sometimes if we're finding that more consistent anti-inflammatory treatment is needed, we'll need to put someone on a prescription that lasts longer. Mobic, or the generic name meloxicam, is one of my go-to anti-inflammatories, which is a once-a-day, 24-hour sustained release anti-inflammatory medications. So for someone that needs a little bit more consistent anti-inflammatory control, taking one pill a day is certainly easier than multiple doses in a day. And I also find that it's easier on the GI system, provides for less stomach irritation when you only have to dissolve one pill a day. Celebrex is another excellent prescription anti-inflammatory that was created to be more gentle on the stomach than some of the traditional anti-inflammatories. And if someone does have issues with Mobic or some of the other over-the-counter anti-inflammatories, we'll try a course of prescription Celebrex for that reason. Topical anti-inflammatory cream is also a mainstay of my anti-inflammatory regimen. These are anti-inflammatory medicines that absorb through the skin to provide anti-inflammatory effect. Voltaren gel, some of you may know this very well, that Voltaren gel just over the past 3 to 4 months has gone over the counter. So it's now available at most major pharmacies, which used to be only a prescription strength medication. It's very effective for knee arthritis. It was FDA cleared and approved for the treatment of knee arthritis, but also gets extrapolated out for bursitis conditions and pain elsewhere due to wear and tear conditions. Tramadol is another medicine. It's a pain medication, also known as Ultram. It is recognized by the American Association of Orthopedic Surgeons as a treatment for advanced arthritis. It is an as-needed pain medication. It is a non-narcotic, but yet it is a controlled substance, so it does require a prescription, and it is monitored as a controlled substance by the pharmacy board. But it is recognized as a legitimate treatment if pain relief is necessary. As far as hip arthritis, sometimes we manage arthritis with injection therapy. If someone has mild to moderate osteoarthritis and still is desiring further conservative treatment, an injection of steroid may be a good conservative treatment step. We do this typically at one of our surgery center locations as an outpatient procedure. A patient is put under very light anesthetic. Excuse me, it's not a general anesthetic. It's actually a monitored anesthetic, but enough to make someone comfortable, but not require a general or any intubation. We then, with an X-ray machine, line up the needle with the hip joint. We're able to go down through the soft tissue into the joint under the capsule, inject a little bit of dye, and that's what the radiographic interpretation on the screen is showing, that a needle is down underneath the capsule. We've injected a little bit of dye that can be visualized under an X-ray machine. And once we know we're in the proper location, we can switch the syringe, keep the needle in place, and deliver a steroid injection into the joint. This can decrease the inflammation. It's often coupled with a long-acting local numbing medication as well for some immediate relief. This is a good alternative in the conservative management options for hip arthritis. We also often recommend physical therapy. We do believe strongly that keeping the muscle strong around a joint that may be developing arthritis is an excellent way to take stress off of the joint. Studies have shown increased blood flow and therefore increased pain relief at joints that are in motion. Managing weight, as we mentioned earlier, is also an effective way. We often recommend low impact exercising, such as water aerobics, light weightlifting, elliptical machine, and stationary biking are excellent ways to stay fit and keep your cardiovascular health up as well. If these treatments are not providing the quality of life that you desire, when should a patient consider joint replacement? Well, quite simply, we do surgery on arthritic hips due to pain and diminished quality of life. If conservative treatments have failed to provide adequate relief, and you're beginning to make daily accommodations due to your arthritic pain, in the end, it's all about decreasing pain, improving function, and to me, that will increase a patient's quality of life. In regards to the most durable long-term solution to hip osteoarthritis, there is no question that total hip arthroplasty is that solution. Total hip arthroplasty was deemed to be the operation of the century. In 2007, this was published by Lancet, British medical journal, one of the most well-respected journals in the world. So this was not an orthopedic journal, but a medical journal that touted the benefits to quality of life of hip replacement surgery. Total hip arthroplasty consists of a titanium implant that allows for recreation of the hip joint. As you can see in some of the diagrams here, it consists of a stem that goes into the femur bone, a shell that goes into the cup or the acetabulum, along with a new ball and socket liner that recreate the joint. Now, hip replacement has been done for quite a while now in the history of orthopedics, but the location of the incision has changed greatly. one of the modern evolutions in the success of total hip arthroplasty is the development and the perfection of the anterior approach. Traditional hip replacement has been through a lateral approach or through a posterior incision that is still a very, very good procedure and may benefit certain patients in certain revision scenarios. But most patients at this point are good candidates for an anterior incision that makes the procedure much more minimally invasive and quicker in the recovery process. The direct anterior approach to total hip replacement is minimally invasive. It's minimally invasive at the level of the incision, about 5 inches. It's also muscle sparing underneath the skin itself. Muscle sparing is important. We spare the muscles, we spare the tendons. All of your muscles and tendons are still there. They're still present. They're still attached. In a traditional hip replacement, we did have to remove some of those muscle and tendon attachments, and we would always repair those. But that still brings on some scarring and some changes after surgery. Often there were restrictions in the immediate postoperative period for the first 6 to 8 weeks to allow for those muscles and tendons to heal to avoid any potential instability postoperatively. By keeping muscles and tendons attached, then those restrictions are not necessary. So the benefits of the anterior approach, not only at the level of the skin being minimally invasive, and then also underneath the skin, sparing the muscles and the tendons, intraoperatively as well, there are many advantages. I have a couple surgical pictures here for you to see. The middle picture is showing a patient that is draped for surgery with both legs available for intraoperative check. The patient is in the supine or on their back position, so it's much more anatomic than a lateral position. Myself, as well as my surgical staff, have access to your lower extremities, so as we go through the surgery, we have many checks and balances to check your overall leg length to make sure that you have equal limb lengths after surgery, which is an extremely important part of the operation. The top right part of the screen shows the x-ray machine that we're able to bring in during surgery. And as we are trialing the implants through the procedure, we can make sure that they're in the correct position within the bone. Again, another check and balance in the procedure that we didn't have before that increases the accuracy of the procedure. The next few slides show some of the steps of an anterior approach surgery, trying to highlight some of the benefits. As we said, the approach is a muscle sparing and tendon sparing approach. So this shows retractors placed around the neck of the femur at the level of the hip joint, spreading the muscles apart without having to remove any attachments. Next, we use a special tool to clean out the acetabulum or the cup portion of the ball and socket joint, preparing to place a final new titanium shell. This provides the substrate within the bone to be able to then replace the cartilage that is worn out. We place a liner inside of the socket. We then move to the upper part of the femur bone, which allows us to expose the femur and place a stem as well as a new ball. And after the hip is reduced, you see the final product. The muscles and tendons are spared and the surgery has been complete. So in summary, the direct anterior approach is certainly a minimally invasive procedure. It's sparing of the anatomy, and it's also minimally invasive at the level of the skin. There are many options, many opportunities for us to fine-tune the leg length and the offset in surgery, and also allows us to obtain intraoperative x-rays for further checks and balance. One of the benefits as well of being minimally invasive and sparing the muscles and the tendons around the hip is that after surgery, because we didn't remove any of the muscles and tendons, we don't have to restrict your range of motion postoperatively and allow those to heal. So we don't have any major restrictions postoperatively. We always ask patients to be careful and progress through their walker and the cane in the first 2 weeks postoperatively. But with general physical therapy, most people are ready for more aggressive outpatient physical therapy and really starting to get to work in the recovery process after 2 weeks. In addition to the minimally invasive nature of the procedure of a direct anterior approach, the modern approach to total joint arthroplasty also includes many new changes to the protocols. This also improves the procedure. One of the things that's changed a lot is in regards to patient education and providing enough information so patients really understand the process. I think a well-informed patient is a patient that's going to do better as they transition through the surgical process, preoperatively, intraoperatively, and postoperatively. I also want to make sure that people understand that this is a well-patient surgery, and I take a well-patient approach to the surgery. This isn't a sick patient model. This is an elective operation for people that want pain relief and want quality improvement in their life and want to maintain their lifestyle. So it's a positive approach to surgery, and I think that shows in my practice. We often talk about prehabilitation instead of rehabilitation, meaning we want people active in therapy, working on stretching and strengthening prior to surgery as much as possible. From myself, you'll obtain a lot of information, a lot of literature to read, and also be directed to legitimate and trustworthy websites that I've labeled here for you. I'm a member of the American Association of Hip and Knee Surgeons. This is our American society for folks like myself that specialize in hip and knee replacement. And there is an unbelievable patient information website that provides a number of different aspects of surgery that you can gain more information about the surgery. Again, the more informed you are, the better you're going to do. A couple of things that I want to highlight about the process is infection prevention. That's a big part of joint replacement surgery. And some of the things that we do is that a week before surgery, we're going to provide an antibiotic cream that actually is placed inside of your nostrils, which we know can harbor bacteria. That's 3 times a day for 7 days leading up to surgery. We also provide a chlorhexidine scrub that we have patients clean the surgical site the night before and the morning of surgery. This will continue around the perioperative period as well as preoperatively as you are prepped and draped for surgery finally. But studies have shown that the more times that the surgery site is cleaned, that we decrease the normal bacterial load that exists on the human skin. In terms of pain management after surgery, this is something that we are also very methodical about. We are very big proponents of multimodal pain management, and we are very much in favor of what Dr. Pagnano at the Mayo Clinic has coined as get ahead and stay ahead. It's just common sense. And we look at this multimodal pain management and get ahead, stay ahead model in a number of ways. We look at your volume and your hydration. We look at blood loss around surgery. We look at pain control, and we look at nausea control. We know that these are things that can provide for less than an optimal outcome after joint replacement surgery. So we're very proactive on the upfront to make sure that that's not the case in the recovery process. We try to avoid hydration. We want to encourage significant water intake prior to the traditional nothing by mouth at midnight prior to surgery. Most of our anesthesia protocols are actively changing. Many anesthesia protocols, depending on the hospital, are allowing clear liquids, water, black coffee, anywhere from 2 to 4 hours prior to surgery. Certainly, we're not allowing any food in the system, as that is still a risk for anesthesia. But clear liquid hydration has actually been found to encourage gastric emptying, making the stomach even more empty, which is safer for anesthesia. So hydration also allows for the response to our medications to be improved, and also for our response to pain medications to be better. Preoperatively, we give people non-narcotic medications, such as simple medicines, such as Tylenol, anti-inflammatory medicines, such as Mobic, that we talked about before. Again, hitting all the different pain receptor sites in the body outside of just pain medication. Typically, anesthesia is multimodal as well. Typically for hips, we prefer to do a spinal anesthetic. A spinal anesthetic is similar to an epidural that some may be familiar with. It's a one-shot numbing medicine in the back that helps to numb from the waist down. It allows for the anesthesia team to have excellent control of the patient's vitals in surgery, It also has been shown to decrease blood loss intraoperatively. Often with a good spinal anesthetic, we can avoid inhalational anesthetic agents and really only do an IV anesthesia. This tends to be better in the postoperative recovery period. We're also very proactive with nausea control. Most patients receive a scopolamine patch. This is indicated by the diagram here. This is basically to limit nausea postoperatively. There are certain patients that need to avoid this intervention. If someone has prostatic hypertrophy or a history of urinary retention, we may want to avoid this, but this is one way to help with nausea for most folks. Also, dexamethasone. Dexamethasone, interestingly enough, is getting recent attention in terms of treating COVID patients for some of the associated inflammation associated with the virus. But we've been using dexamethasone for years around our joint protocols. We have good studies that show IV dexamethasone prior to anesthesia and 24 hours post-anesthesia can greatly benefit inflammation as well as pain thresholds. Intraoperatively, we manage blood loss. One of the revolutionary medications in joint replacement surgery in the last handful of years has been tranexamic acid. This helps limit blood loss. It's very safe. There are very little contraindications to this medication. It's found to be very safe, and it has statistically been proven to decrease blood loss around hip replacement as well as knee replacement. There are different forms, IV, topical, and oral, and we do customize that for the patient based on any previous medical history. Some of the relative contraindications and more strong contraindications are patients that have had previous history of clotting, whether that's blood clots, pulmonary embolism, heart attacks, or strokes. Intraoperatively, we are also very proactive with nausea control in addition to the scopolamine patch and preoperative medications for nausea. Intraoperatively, we're giving nausea control all along the course of the surgery. We also provide for a peri-articular injection. This is demonstrated here on a knee replacement surgery, injecting all of the soft tissues with a number of different medicines to provide long-acting pain relief after surgery at the surgery site. Again, this has been a revolutionary treatment to help people in the postoperative period feel well, have less pain, and be ready to participate earlier with physical therapy. Postoperatively, we have to manage some things as well. We have to prevent blood clots, one of the higher risk items after a surgery. Ambulation is the primary agent, and luckily with hip and knee replacements, we're allowing people to get up and move the day of surgery, often within hours of their operation. Mechanical compression is certainly a part of that process, whether it's traditional compression hose or mobile calf pumpers that help the blood move through intermittent squeezes and mobile pumps. We often do aspirin as well, sometimes more aggressive blood thinning agents for different folks based on their history. Skin closure is a big part of this as well from a cosmetic standpoint. We don't use any drains. Those have become almost a thing of the past. We use dissolving sutures and skin glue. We often use a silver impregnated dressing that is waterproof, and patients can shower the day of the surgery. The silver dressing, it can be replaced in 1 week and provided at the hospital, occasionally in revision scenarios or for people that may have wound healing issues or other issues that may cause slower wound healing. We also have personal wound incision management systems such as the Prevena that is displayed that can be an excellent 1 week dressing for those folks. So a lot of options and a lot of thought goes into the skin closure and the dressing used after surgery. After surgery, we utilize a lot of simple measures as well. This is also part of the pain control regimen. We use a lot of compression to keep the swelling down, and we also use a lot of ice. Pictured are a pair of traditional compression hose as well as mobile care pumps. Typically, we need one or the other. I do think that the mobile care pumps have proved in the literature to be one of the best ways to prevent blood clots after surgery. And the nice thing about the mobile pumps are once those are on, the traditional hose can be removed. If someone cannot tolerate the pumps, then yes, we do need to use the hose in the first 2-week period, but either device is for only the first 2 weeks. After hip replacement, we also recommend the use of some compression shorts. I have people pick up a pair of compression shorts from a local sporting goods store, and that's an easy way to provide compression to the hip area to keep the swelling down and allow the wound to heal well. Pictured above is also a ice machine with a dressing that has cold water circulated through it, an excellent way to keep the hip iced down after surgery. Often discharge prescriptions from the hospital or the surgery center include aspirin, a long-acting narcotic medicine for only 4 doses in the outpatient arena, some as-needed breakthrough pain medication. This can be in the form of oxycodone, hydrocodone, or as mentioned before, a tramadol. Again, this is something that we customize with patients regularly. Often an anti-inflammatory, an antibiotic, and a medicine known as Vistaril or hydroxyzine. It's essentially a Benadryl-type tablet. It's an antihistamine medication that helps with multiple helps in multiple aspects of the recovery process. Often it can help with sleep at night. It can help with anti-itching after narcotic use, since that is something that is a known side effect, not necessarily an allergy, but a known side effect of narcotic use, and certainly some Vistaril can help with that. There can also be some anti-anxiety properties with Vistaril or hydroxyzine as well. So a number of different medications in the postoperative period to help a patient have the most successful outcome and a smooth postoperative course as possible. So at this point in time, I'm going to go ahead and stop sharing my screen. I hope this outlines a lot of different aspects of hip pain and some of the options that you might have. I'm going to go ahead and revert to the Q&A and provide everyone an opportunity to have some questions answered. Okay, so I'm going to go down the list at this point in time. First question is, how do I know when I need to see an orthopedic surgeon for my hip pain? And quite simply, as we mentioned in the presentation, it really comes down to quality of life. The 2 aspects that I would do surgery for would be pain and decreased function. But these are the same things that I would see a patient for and at least initiate a good conservative treatment plan. So pain and function is the answer to that question. When do you need to see an orthopedic surgeon? It really comes down to if you're having too much pain that you can't handle at home, or if your function's going down and you desire a higher quality of life. The next question is, how long do hip replacements last? Great question. So technology has changed greatly in the world of total joint arthroplasty in a short period of time. As I showed you in the diagram, that a hip replacement consists of titanium components that grow into the bone. Hip replacements do not require any cement. So the titanium pieces go into the bone, and those, once they are fixed to the bone and the bone grows into them, those are essentially lifelong devices. Those are part of the body once the body accepts those pieces of titanium. That occurs over the course of 6 to 8 weeks, that initial ingrowth. That remodels over a series of months and then becomes a lifelong, lifelong fixation. Now, the portions of the hip replacement that actually touch the ceramic ball and the polyethylene liner that is inside of the acetabular shell, those portions do wear down a little bit. And specifically the polyethylene liner. Polyethylene is essentially a medical grade plastic material. And modern we have about 15-year retrieval data on revision surgery on modern polyethylene that is showing negligible polyethylene wear. So even though we don't have a full 25, 30 years of data on modern polyethylene just yet. We can comfortably say at 15 years, we're seeing negligible polyethylene wear, and extrapolating from the basic science benchtop table tests on simulating wear, that 25 to 30 years seems to be a realistic number for folks. Now, one of the best benefits of modern hip implants is that they're modular. The liner can come in and come out of that acetabular shell. So once the titanium is grown into the bone, if we're ever found to have someone that has had a hip in so long that the polyethylene is worn out, we can go back in as long as the rest of the hip is looking good. We can go back in and replace just the movable parts, which would include the liner and the ceramic ball. That makes a less of a surgery and does not require a full overhaul of the entire hip replacement. Next question is, what are my limitations after hip replacement surgery? Another good question. As I mentioned, anterior hip replacement surgery is minimally invasive. We spare the muscles and we spare the tendons. Because of this, I do not have any major restrictions that I place on patients after surgery. As long as everything goes as planned, as long as the bone is in good condition, as long as the muscles and tendons are intact and in good condition, then no restrictions after surgery. As I mentioned, that goes with some common sense to say that in the first 2 weeks post-operatively, we do want to be careful. We walk through gait aids post-operatively. A walker initially is how we get patients up and mobilize them the day of surgery. Folks are on a walker for maybe 1 to 3 days. Afterwards, folks go onto a cane, just a single prong, simple cane. That cane can be used for a week, maybe 2. But most patients at about 2 weeks are beginning to get rid of their gait aids and begin walking on their own. In that process, as early range of motion begins with in-home therapy or outpatient physical therapy, no major restrictions, not like traditional hip replacement. I don't recommend any high impact activities such as jumping or heavy lifting until we get that initial ingrowth, which I said would take about 6 to 8 weeks. At 3 months, I allow for unrestricted activity in exercise or in activity. How long is the recovery process after a hip replacement? I mentioned a little bit of the transition through the gait aids. We typically do anywhere from 4 to 6 weeks of therapy. Sometimes that includes a couple weeks of in-home therapy to bridge the gap to when a patient may be able to drive again. Typically around 2 to 3 weeks is when we expect that to occur. Outpatient therapy then begins, and that can go anywhere from 3 to 6 weeks, depending on the individual. So the recovery process is a spectrum of healing. I often say that in 6 weeks, I expect an anterior total hip to be 75% recovered. In 3 months, I expect an anterior total hip replacement to be 90% recovered. And the remainder of that recovery comes from continuing to work out, continuing to get the muscle strength back, continuing to work through the stretching as some of the muscles and tendons around the hip have become tight over time. They need to be stretched out as well to improve the range of motion that had been lost pre-operatively. So the process, again, 75% improvement at 6 weeks, 90% or so recovery at 3 months, and then fine-tuning that last remaining 5 or 10% for the patient, for that individual, over a 4 to 6 month period. Next question is, do you do hip replacements as outpatient surgery? And the answer is absolutely. So every week I do inpatient hip replacements and I do outpatient hip replacements. And a lot of that depends on patient factors. The reality is that the protocol is the same. The procedure is the same. So it proves that the surgery can be done in a rapid mobilization and in a quick fashion in the surgery center. But there are some limitations with insurance and age, and sometimes medical risk factors that make a patient a better candidate for an inpatient or one night overnight, or a outpatient surgery. Typically, Medicare, under Medicare guidelines, does not allow for a hip replacement in an outpatient surgery center. That's just an insurance rule at this point, and that may change here in the near future. But patients on Medicare that require a hip replacement can be done in the hospital as either a same-day discharge or a one-night overnight. So even though it's not technically an outpatient out of the hospital outpatient department, it can certainly be done as a same-day, more of a rapid mobilization protocol, just like in the surgery center, and get the same experience. But every week we do outpatient surgery, and that's an excellent opportunity for people that are not on Medicare, on private insurance, and do not have any medical risk factors that would make them a higher risk for surgery, and allows them to also be more cost effective because they do not have the extra costs that a hospital may charge by having a hospital room and hospital supply. Some of the medical risk factors that may not allow someone to have a surgery done same day out of a surgery center may be excessive, sleep apnea with an excessively high CPAP setting. That's one of the hard stops in a surgery center, because the anesthesia team feels that would be at an elevated risk of someone not oxygenating well, requiring prolonged oxygen, and being transferred to a hospital. Sometimes different cardiac events in the past can lead to not being able to be done in an outpatient surgery center. And lastly, weight can be a factor. BMI, the height to weight ratio, if it's elevated past a certain degree, can sometimes be one of the risk factors that may allow or may need someone to be done in a hospital setting instead of the outpatient arena. I had a question here about after hip replacement surgery, can you play tennis? Can you jog? Can you function as you did before the pain started? These are great questions about function and activity after surgery. So after hip replacement surgery, the one activity restriction that I do recommend to patients is that from an exercise standpoint, I do not recommend long distance running as a regular form of exercise. I do think that is one higher impact activity that can lead to accelerated wear over time. Now, I do say that with a little bit of a disclaimer, because I do have some long distance runners in my practice that I have done hip replacements on, and they understand this and they are willing to accept that risk. And that's something, and that is an activity that makes them whole. And I can certainly understand that, and I can respect that. So I think that the tread on the tire of the polyethylene, knowing that with normal wear, 25 to 30 years is the estimated life, knowing that that there's modularity, knowing that we can remove that liner, knowing that we can replace that liner with a smaller surgery in a revision scenario than replacing everything. Some are willing to take that risk. Can a patient play tennis? Absolutely. Absolutely. I don't have any issues with that. Function as you did before the pain started, that is always our goal. There's always our goal. The risk of surgery is always that there could be some remaining pain, but by far and away, patients with an anterior total hip that go through a good recovery process, participate in therapy, they get their range of motion back, they get their strength back, do function as they did before surgery, and can lead active and athletic lives. Patients can play golf, patients can ski, patients can swim, patients can do resistance training. So lead a very active life, absolutely. I have a question here about hip pointers. Hip pointers are often associated with pain over the very front of the iliac crest, where we talk about this is in the anterior superior iliac spine. And I've actually got a diagram here that I can relate to. This is a model of a pelvis. This part of the pelvis right here in the front can become irritated. It's a source of attachments for some of our muscles and our tendons. So especially teens that are still undergoing development, there is a growth plate on the top of the iliac crest of the pelvis, both sides. And as a teen may be growing and there may be excessive pull as the muscle tension is increasing, as the individual is growing, that can pull on this growth plate and cause inflammation. So a hip pointer is often an inflammatory condition localized to the ASIS. There can be some AIIS pain as well, a little bit lower, but both conditions are caused by excessive pull or straining of the muscle and tendon attachments to those areas. I would treat that with anti-inflammatories, similar to what I mentioned before, a course of oral anti-inflammatory, some topical anti-inflammatory, and then it really comes down to physical therapy, getting that patient into a good physical therapist for stretching, strengthening, and certainly a period of rest. I see another question here. How long do they need to stop playing sports? That may vary patient to patient. That's certainly a potential 6 to 8 week rest period for an acute hip pointer with an adequate anti-inflammatory, with an adequate stretching regimen monitored by a good physical therapist. That 6 to 8 weeks of rest should help that condition settle down. I see a question here now about post-operative hip replacements having hernias. So I would ask Tom, who posted the question here, are we talking about hernias at the incision of the anterior hip, or are we talking about more abdominal type hernias or groin hernias? And then the follow-up question to that was, have we seen complications after injections for hips? So certainly when we do steroid injections into the joint for hip arthritis, there's always a small risk of infection anytime we put an invasive needle into the body. There's always a potential for infection, albeit that's a very, very small risk, but that is possible. The other issue with steroid injection in and around native cartilage, there's always been a concern about the health of the cartilage after steroid injection. I think that there is a limit, Tom, to the amount and how often and the frequency of those injections. I think too much steroid can certainly damage the cartilage. But if we space out injections 3 to 4 months, and a patient is clinically improving, I think that the benefits can outweigh the risks. There's very, very rare cases of a chondrolysis where the cartilage is severely affected by a steroid injection. That can be also seen in shoulders with shoulder injections, but that is a very, very rare condition. So the follow-up on the hernia was abdominal hernias after hip replacement. And I have to say, Tom, that I haven't seen that where we are making our incision, and this also follows up with another question here, is where will the surgical incision be? As I pointed out here, I have another diagram I can show. We'll see if this will project on the screen. But this model here shows the location of the incision in the front of the pelvis right here. So you can see underneath that this is the crest bone of the pelvis, and you can feel that bony point of your hip right in the front, almost at your belt line. We typically, from the very point of that hip, come out a few centimeters and laterally down the front of the thigh. So if you can see this line right here, this blue line, that is the location of the incision. Another question, how many post-operative hip patients can do squats after the hip replacement? I have seen a number of patients do high-level squats. I think it directly correlates with the patient's physical fitness overall. I think it has to do with people that are interested in that amount of weightlifting. But I do allow for squats, and I think it's all about controlling the weight. I think that there's a certain level of common sense, again, that I think we want to try to minimize the weight. But I do have some fairly aggressive weightlifters in my practice that are interested in doing that. Again, that's the activity that makes them whole, and they've accepted potentially some increased wear on that bearing. But I think that the body weight squat is a very underrated exercise. I think it's so important for the quad strength, as well as the gluteal strength and the hamstring strength. And it's such a dynamic movement that I think it really can improve people after hip replacement and just for general functional training in life. So I am a fan of at least a body weight squat, especially for post-operative patients. Question is, how long would I be off work for a hip replacement? And this is obviously a question that comes up on almost every surgery that I do. It does vary. It depends on the individual. COVID has provided a different avenue, such as we're doing in this format here for virtual work. Some people are going back into doing some element of work 2 weeks after if they have primarily a virtual job, desk type job. Someone that needs to go back into the office maybe could do so at 4 weeks if they don't have a lot of manual labor. Someone that has more walking associated maybe then gets into more of a pushing, pulling kind of a work requirement that does not have the ability to get back in under a light duty restriction, maybe looking more at 6 weeks after. Again, as I mentioned before, 6 weeks in, I think a patient will be about 75% improved. I don't expect 100% improvement at that point, but very functional. And I often try to customize the return to work prescription based on the individual as well. If someone has the ability to do some light duty and we transition back into light duty for a couple weeks, often that can really help bridge the gap into getting into a full routine with work. Some of our more real heavy duty machine operators and heavy lifting jobs may require, as I mentioned, 6 to 8 weeks before a full return to work and lifting. I had a question from a audience member that asked if I am board certified and why is that important? I am board certified in orthopedic surgery, and I was fellowship trained, meaning an extra year of training in addition to my orthopedic surgery training to specialize in hip and knee replacement. I think board certification is important because it puts you through a rigorous training and board examination process that makes sure that you are up to standards for standard of care and treatment. And I also think that in the world of hip and knee replacement, and hip replacement specifically what I'm talking about here today, I think it's important to have a surgeon that is specialized and focused on that area of the body. I think you're going to be provided with some of the best care by physicians that are specialized in doing a lot of that work. I think that's your best opportunity to have an excellent outcome. I have a question here that asks, can an X-ray be used to pinpoint a hip issue, or would an MRI always be necessary? And I would respond that x-rays are our baseline treatment. So if you came to see me in the office, an x-ray is going to be the first line of diagnosis. But depending on the underlying conditions, sometimes we need to get an MRI. Now, an x-ray shows bone. And as I mentioned, arthritis is the wearing down of the cartilage. We cannot see cartilage on an x-ray. An MRI will allow us to see cartilage and some of the soft tissues. There are other conditions that can occur inside the hip where it may not be arthritis. It may be a labrum issue. It may be a tendon issue. And that may need an MRI to pinpoint that problem. But osteoarthritis, if it's primary osteoarthritis, joint space narrowing and bone spur formation and some of the common changes of arthritis is best diagnosed with just plain x-rays alone. Another question is, which offices do I see patients at? At OrthoNeuro, we do have many offices all over town. I see patients in Dublin, in Westerville, and in Pickerington. I also see patients in Grove City. Our Grove City office hasn't quite opened yet since we did shut that down through the COVID pandemic. But currently Dublin, Westerville, and Pickerington are where I can be seen. I do anticipate that we will get the Grove City office back up and running in the near future. Hey, Tom, I certainly do. How long do I wait between hip replacements on the other side? So if someone has advanced hip arthritis bilaterally that comes in and is almost at a point where they can use a hip replacement on either side, and they were interested in staging those procedures, I do it 6 weeks apart. I do that because the literature has shown us that doing them simultaneously, it leads to increased anesthesia exposure, potential increased infection. And I think it's very difficult for patients in lower extremity arthroplasty to have a joint replacement on both sides because there's not one area that can offload it all. I think that in that scenario, you're only giving that one side, or you're only going to be able to give, in the scenario of doing them both at the same time, you're only going to be able to give each side 50% of your attention. I think that's more intensive, especially on the knee replacement side of things, but I think it certainly correlates with the hip. So for me in my practice, I recommend 6 weeks apart, and that allows us to see you through the 2-week visit and then the 6-week post-op visit. Again, most people 75% better at that 6-week visit. And if you're doing great, you're doing well, your incisions healed good, you had a good experience, then we can turn right around that following week and do the other side and match you up. How do I schedule an appointment? So scheduling an appointment, I would go to orthoneuro.com. We do have an online scheduling platform, so you can do it right from there. You can see where I'm available and fill in a slot. You can certainly call our main number and it'll go through our call center. And if you request me as your provider, and if you have a request on your location, you can simply do that through the phone system as well. How long does it take to get in? Well, that typically depends on the time of year. This fall time, admittedly, is a higher demand time. The reason that is because of the insurance world. Often deductibles turn over at the very beginning of the year. So if people have had chronic arthritis issues and they know that they're close to a surgery, that the fact that they may have met their out of pocket on their insurance plan may cause them to get in at the end of the year and try to get that surgery complete if they know that that's appropriate and it's needed. So we do see increasing demand at this time of year. I would say I usually try to keep my schedule at a pace where you can be seen within my office, specifically within a couple weeks. That can vary depending on the time of year. Certainly at OrthoNeuro, if someone needs to be seen, you can see a specialist within 24 hours. It may not necessarily be my office, but at OrthoNeuro, we will have you see a specialist within 24 hours if needed. And then on my surgery schedule, most times a year, I try to get people in for people that come into the office and really do need surgical intervention, get you into the surgery schedule within 4 to 6 weeks. And that can certainly vary throughout the year as well. I have a great question here about if you have a hip and a knee problem, which one gets fixed first? And this is a very common scenario that comes up with osteoarthritis, as it is a genetic phenomenon. So it's not uncommon for people to come in with arthritis in both sides or issues in both locations. And the answer is that if you have bone-on-bone arthritis in your hip and you have bone-on-bone arthritis in your knee, we always start with the hip. We always start with the hip. The hip is an easier recovery than the knee. And the hip provides a tremendous amount of rotation of the lower extremity. And that will make then the recovery, after going through a successful recovery on a hip, it will make your knee recovery much easier. If we try to do a knee replacement first and someone cannot move their hip above that joint, therapy is a struggle. And often we find that someone does not optimally rehab, and they do not optimally improve all of their range of motion on that knee because of the arthritic hip above. So we'll start with the hip and work our way down to the knee if that's necessary. Well, everybody, I appreciate your time. We've gone a little bit over an hour, but it looks like we've answered all of the questions on the list. I certainly appreciate your participation. I'll hand it back over to Heather if there's anything that Heather needs to do to wrap us up.
Thank you very much, Dr. Palmer. That was great. If you have any additional questions, please feel free to reach out to OrthoNeuro at 614-890-6555, and we will get those questions answered. Thank you for joining us. Bye-bye.